Inadequate oxygenation to the disc produce ischemia and swelling of the disc. Pathology is at short posterior ciliary artery. NaION is the most common ION with mean age 57 to 65, 1 in 10,000 per year. Crowded disc, small disc with minimal cup is often important risk factor for NaION. Other risk factors are hypertension, diabetes, OSA, hyperlipidemia, ischemic heart disease, obesity, high blood pressure, and tobacco usage. Drugs like Viagra, erectile dysfunction drugs, amiodarone, vasoconstrictors like nasal decongestants, and cocaine are also risk factors. Clinical features: rapid onset painless unilateral vision loss associated with altitudinal field defect and RAPD. Optic disc is edematous at onset, and although pallid edema is hallmark of AION, hyperemic is most common in NaION. Disc often swollen diffusely, but a segment of more involvement is frequently present, commonly flame-shaped hemorrhage localized to adjacent area of swelling. For example, 55-year-old male patient, obese, hypertension, OSA with BP 160/100 and vision 6/60 with RAPD and neurological intact and full EOM. In another case, left eye already had NaION in the past, in the right eye painless vision loss few days back, and now he came with 20/20 and 1 week later he developed NaION in which field showing inferior altitudinal defect and it got worsened within 1 week, vision fallen below to 6/60. So common cause of optic neuropathy more than 50 years is AION. It can be anterior, posterior or arteritic or non-arteritic. No proven therapy. 80 mg prednisolone for 2 weeks, gradually tapered, improve visual function and visual field at 6 meter in some studies. Aspirin, no improvement, no other proven therapies. Reduction of vascular risk factors, medication review and check ESR and CRP, avoid hypotension, anemia or further strategies. Next is arteritic ION is more than 50% is giant cell arteritis. Other causes are SLE, Wegener's, Behçet's, others. So predilection for large vessels for aortic arch and temporal artery. It is an ophthalmological emergency. More than 50 years we have to suspect. Arteritic ION presents like ION, but 75% have typical systemic symptoms and disc is swollen, mostly paler. Pallid swelling is pathognomonic. And other fundus findings of giant cell arteritis include branch retinal artery occlusion or central retinal artery occlusion showing cherry red spot. And FFA choroidal hypoperfusion indicates multifocal ischemia on the fluorescein angiography. Workup include ESR, CRP and platelet, fibrinogen, hemoglobin and temporal artery biopsy. Should be treated with IV steroid, methylprednisolone 1 gram for 3 days, followed by slow taper of oral prednisolone, and aspirin 100 mg daily can be given. And ION may complicate non-ocular surgery, CABG, spinal surgery, where there is hypotension is the reason. Differential diagnosis of post-operative vision loss include ischemic optic neuropathy, retinal artery occlusion or angle closure glaucoma, or cortical blindness. Bilateral occipital stroke can cause cortical blindness and epithelial irregularity. There is no effective treatment in post-operative cases. Prognosis is poor. Significant improvement in minority of patients. No example: 79-year female present with monocular vision loss in right eye for 2 weeks back, and now complete loss of vision in right eye for 2 days with swollen and sore nerve on the temporal area, 6/60 RAPD present. Visual field showing large central defect and normal left eye. So giant cell arteritis cause 90% of cases vision loss, and it can produce anterior or posterior ischemic optic neuropathy, and it is due to granulomatous vasculitis. Elevated ESR and CRP is more specific, and thrombocytosis is seen in 50% of giant cell arteritis, may increase vision loss, and transient ischemia also seen commonly. Fellow eye is involved more common, and aortic complications like aortitis, ectasia, aneurysm, mesenteric ischemia, myocardial ischemia, cerebrovascular ischemia is common. ESR more than 100, CRP more than 10 if it is there. IV methylprednisolone 1 gram per day for 3 days, followed by 70 mg per day discharge, and aspirin 81 mg per day. Temporal artery biopsy on day 6. So patient of age more than 50 years with the typical giant cell arteritis symptoms, we have to do field test and temporal artery biopsy and ESR and CRP and one MRI, so that we can rule out other causes of this disc swelling and Intravenous steroids are more effective in treatment in giant cell arteritis.